Dear students, today we'll be learning about the flexors of the forearm. So now, in summary, the flexor compartment of the forearm, to understand that you're looking at a forearm and from the anterior aspect. And there are the bones which we'll be studying today, and lastly the group of muscles. They are organized and they are included in this flexor compartment of my forearm. Now these are the bones, and we'll be learning now the radius and ulna. These are the two bones who are present in my forearm region. Let's label them. You're looking at the radius, and this is the head of the radius. And then you're looking at the neck of the radius, and now this part of the radius which is facing medially, that is the radial tuberosity. And then there is an intraosseous border. Look at, this is the intraosseous border of the radius, and this is the intraosseous border of the ulna. At the bottom we are looking at the styloid process of the radius, and then this is the most common site where my radius bone goes fractured. And there you are looking at the ulna bone, and then ulna also have a tuberosity, so we call it ulnar tuberosity. At the lower end of the ulna we are looking at the styloid process of the ulna. And then these are my intraosseous borders, both from the radius and ulna, and they are connected through a very strong thick membrane, and that is intraosseous membrane. And now this fracture site at the distal radius, we call it Colles fracture. And now here you can see the both radius and ulna, they are articulated, and look at this thick membranous structure, the intraosseous membrane which connects the two bones. Now when we take a section, when we look at a section of the forearm, what is visible? The outermost core is the skin, and then underneath we have always a superficial fascia which has a fairy layer and a membranous layer, and within this we have the veins. Which veins? The superficial veins. They are laterally we have the cephalic vein, and medially we have the basalic vein. And then this green deep ring is my deep fascia, and then we can see there are two bones. We have just seen them before. These bones are radius, which is located laterally, and the ulna, which is located medially. And then you can see that there is an intermuscular septum which divides my forearm again into anterior and a posterior compartment, and in between these two bones, the radius and ulna, that is this number 1 is my intraosseous membrane. So now the anterior compartment, the group of muscles who are located within my anterior compartment, what is their job? They are flexors of the wrist joint and the digits, and they are helping in bringing pronation at the proximal, distal, radio-ulnar joints. And the nerve who controls these muscles, that is my median nerve through its different branches. And then within the anterior compartment there is a separate small compartment, and the muscles who are present in this compartment, they are not many. The digit 4 and 5 of a muscle which is known as flexor digitorum profundus and flexor carpi ulnaris, and these muscles are innervated by my ulnar nerve. And now coming to the posterior compartment, so that will be opposite to my anterior compartment. So within this compartment, the muscle who are present, they are extensors of my wrist and the digits, and they are helping in bringing supination. And the nerve who controls them, that is the posterior intraosseous nerve. Posterior intraosseous nerve is one of the deep branch of my radial nerve. Now just put your hand like this at the medial epicondyle, and now if I can label it, so these 4 fingers are naming some muscle, and we'll be using this method for understanding and for learning of the muscle groups. So now before going into the muscles, let's talk about the cubital fossa. Look, the skin has been removed at the elbow region, and this region is famous with the name of cubital fossa, and you can see the meshwork which is made by these superficial veins. And then you can see the fat has been removed, and now you can see the more detailed superficial veins have become visible, and you can see through this deep fascia you can also see the muscles who are present, and there you are looking at the biceps brachii, and we are clearing it more and more. So look at the deep fascia is removed almost, and you can see the muscle getting clear up, and these veins are nicely visible to us. And now look at it, the deeper dissection, and we have separated out the muscles, and now we are at the vessels. And look at it so nicely, you can see in this dissection the biceps brachii, its tendon, and the aponeurosis, bicipital aponeurosis, and look at this brachial artery, it goes behind it, and lateral to it we have the median nerve, which is not shown in this image. And there we can see now this triangular area. This is my cubital fossa. Look at its boundaries. Medially we have pronator teres, and laterally we have brachioradialis. The base where we can draw an imaginary line which runs between my lateral and medial epicondyles, and the apex where the two muscles crosses over each other. And now this is where you can see the similar thing, brachioradialis and my pronator teres. And there you can see its contents, but before there, this muscle, the biceps, makes the base floor of this cubital fossa, and then you can see its contents. The primarily we'll see here the brachial artery and median nerve, but if we stretch it a lot, then we may find this radial nerve and then its branches, but that is not normally visible, only if we retract this brachioradialis muscle. So now this is this slide, what you are expected to know about the cubital fossa, its boundaries, and then what are the contents, which is a must know type of information. And now you can see the muscle who are contributing to the floor of my cubital fossa, and these are the bones who are there within my forearm. Everything is labeled for you. Now let's try to bring everything one by one. So now, for understanding, we divide the muscles who are present in my forearm in three groups: the superficial layer, then the innervating nerve is the median nerve. And now you can see a muscle which arises by two heads, and this is going towards the radius. This muscle is my pronator teres muscle. And through the two heads of the pronator teres, we have the passage of this median nerve, and if there is an hypertrophy of this pronator teres, any of the head, that might result on pressure symptoms which can affect the performance of the median nerve. And that is called, if that happens, we call it Pronator Syndrome. And then we can see this gray thing, and that is my common flexor origin, and this common site from where I can drive a muscle which goes radially, and this is going to the base of my second digit, and this muscle is my flexor carpi radialis. And then next to it we had a muscle which is also coming from the common flexor origin, but it becomes gray here, and it has to go into a triangular area called palmar aponeurosis, and this muscle is named as Palmaris longus muscle. Guys, this muscle may be absent in 20 to 25% of the normal people. This muscle is not there. And now on the ulnar side we have this muscle which goes and split to be attached on the base of my fifth metacarpal and to the pisiform bone. This muscle is also coming from the common flexor origin, and that is my flexor carpi ulnaris. Now you can see that along with the lateral to my median nerve we have the brachial artery, and this brachial artery, it becomes radial when it enters in my forearm at the neck of my radius. And we can record the radial pulse in a location just at the base of my first digit. And then you can see my brachial artery bifurcates into radial and ulnar branches. You have seen, and now you can see this ulnar artery running between. But please be reminded, this ulnar artery, you need to be very specific. It is located in which of the tendon, as if I have not placed all the muscles. So don't get deceived. Don't write in an answer that your ulnar artery is present between palmaris longus muscle and the flexor carpi ulnaris. There are more muscle who has to be chipped, who has to be pitched in. Now you can see also there is another nerve which has been showing up, and that is going in between, and this is going behind my medial epicondyle. So this is my ulnar nerve. Now the injury, any inflammation, any overwork at my medial epicondyle involves this area, and that leads to medial epicondylitis, and that is famous with the name of the golfer's elbow. Now the actions produced by these muscles. So these muscles, they pronate the forearm and flex the wrist. Who pronates? Pronator teres. And who flex? The flexor carpi radialis and flexor carpi ulnaris. Palmaris longus, its job is just to stretch this palmar aponeurosis. Now we have talked about the first layer. Now let's look at the intermediate layer. Now look at this huge muscle which is coming from my common flexor, medial epicondyle, from the front of my ulna and from the front of my radius, and then it merged to become one, and also it's coming from the intraosseous membrane, and it splits in 4 tendon, and this muscle is going towards my digit, so we call it flexor digitorum superficialis muscle. And this muscle splits into 4 tendons, and they are going to the bases of my middle phalanx on digit 2, 3 and 4 and 5. And you can see when this muscle is attached distally, it splits into slips, and they are going on either side base of my second phalanges on 2nd, 3rd, 4th and 5th digit. And now look at it, same, my brachial artery becoming radial, and then we are looking at the ulnar artery. Now you can see it's going medial to my flexor digitorum superficialis, and then more medial to it we'll having flexor carpi ulnaris. So it's between my tendons or my muscles, flexor carpi ulnaris most medially, and then we have this ulnar artery, and then we have the tendon of the flexor digitorum superficialis. Now we can see that this median nerve, it crosses and it's going lateral to my flexor digitorum superficialis. And now this is the ulnar nerve. So what is the job of flexor digitorum superficialis? It flexes the wrist and the digits 2nd, 3rd, 4th and 5th at metacarpophalangeal joints and proximal interphalangeal joints. So where is, this is my metacarpophalangeal joint, this is the metacarpal, this is the first phalanx, metacarpophalangeal joint, and then this joint is what? My proximal interphalangeal joint. So we have talked about the intermediate layer. Now let's talk about the deep layer. There we have 3 muscles here. The one at the bottom, that is my Pronator Quadratus. This muscle has 4 angles. Now let's look at the arteries which we were looking before. So there is my brachial who becomes the radial, and then it gives its ulnar. Both of them, you can see them. When it reach at the neck or the head of my radius, it splits into radial. Radial goes on to the radial side and ulnar goes on to the ulnar side. Now this ulnar artery, it gives a branch which is going towards my intraosseous membrane, and this branch is called the common intraosseous artery, which is given by my ulnar artery. And this one splits in 2. One goes in front of the intraosseous membrane and one goes behind. The one who goes in front, we call it anterior intraosseous artery, and one who goes behind, we call it posterior intraosseous artery. So anterior intraosseous artery supplies my flexor, deep flexors of my forearm, and posterior intraosseous will be supplying the extensors of my forearm. So why we call it anterior and posterior intraosseous? Because these arteries are located in front and behind the intraosseous membrane. And now we can see who's this. That is my median nerve. And this median nerve, it gives, you can see it's a deep branch, and this is my anterior intraosseous nerve. And there we can see the ulnar nerve. Now look at it. The tendon, as we said, tendon of my flexor digitorum superficialis, just at the distal attachment, they split and they are attached on the basis of my middle phalanx. And what is the function of my pronator quadratus? Number one, name says it's a pronator, it pronates. And second thing is, at the distal end, it's connected between the radius and ulna, so it prevents the separation of these two bones. And now let's put more muscles. Look at this huge muscle which is coming more from the ulna, and that is my flexor digitorum profundus. Now this flexor digitorum profundus, look at the part of this flexor digitorum profundus which goes to my fifth and the fourth digit. They are innervated by the ulnar nerve, and the part which goes to my index and the middle finger, they are innervated by the median nerve through its anterior intraosseous branch. And then you can see that these tendons, they pass between the tendons of my flexor digitorum superficialis, so they can reach to the bases of my second, third, fourth and fifth phalanges. And now, what is the job of flexor digitorum profundus? It flexes the wrist and then digits. Which digits? Digit number 2, 3, 4 and 5. It has to do nothing with my first digit. And what joints? When we'll talk of an action, we always should talk of a joint. Flex is at the wrist. Second, flexion at the metacarpophalangeal joints, proximal interphalangeal joints and distal interphalangeal joints. So these are my proximal and these are my distal interphalangeal joints. And now this last muscle of the deep group, that is going towards my first digit, and this muscle is nothing but flexor pollicis longus. And this flexor pollicis longus, it goes and get attached onto the distal phalanx on the first digit. So now let's summarize. In the anterior compartment of the forearm, what is the job of this muscle? They are the flexors of wrist and the digits, and they are also pronators. The nerve who controls here is the median nerve, directly and through its deep branch, which is the anterior intraosseous. And we also have a contribution from the ulnar nerve, which supplies the flexor carpi ulnaris and ulnar half of my flexor digitorum profundus, the one which goes to the fourth and fifth digit. The arteries are here ulnar and radial arteries, direct branches and their deep branches. So now we have divided this compartment for our understanding in three layers: superficial, intermediate and deep. And we have talked about these muscles. So now another very important concept. Look at, we are looking at any digit, but this is not first digit. So what are we looking at? This is my metacarpal, proximal phalanx, middle phalanx and distal phalanx. So now this is the palmar side, and look at it. On the dorsal side there you can see a tendon, a long tendon of my extensor digitorum, and this tendon is being stabilized by the help of this extensor hood, and that stabilizes, and we call it dorsal digital expansion. And the job of this dorsal digital expansion to stabilize this tendon, so it should not be moving from its location. And on the palmar side, you are looking at the tendon of my flexor digitorum profundus, and look at it, as we have discussed, it was passing through the splitted part of my flexor digitorum superficialis to reach to the base of my distal phalanx. And now these two tendons, they are enclosed in a sleeve which is made up of synovial membrane, and that one is my flexor synovial sheath. And then look at it, these are those factors which keeps this flexor synovial sheath to be adherent to each individual digit, and these have a names. So this is the annular part and this is the cruciform part. So now inflammation, if I got any injury, any prick at the tip of my finger, it may result in inflammation of the synovial sheath. If the sheath is involved, we call it synovitis, and if the tendon is involved, we call it tendinitis, and if they are together, we call it tenosynovitis or tendosynovitis. These terms you should be very clear about them. Now we are looking at the arterial plan of my whole upper limb, and we are looking at the subclavian. It becomes axillary, it goes brachial, and then it becomes radial and ulnar, and when it reaches the palm, it becomes superficial and deep palmar arch. But how we see them? So this is a special type of technique. A contrast has been injected within this arterial plan, and you can see the same plan extended from within my forearm. So this is called angiogram, and you can see the radial and the ulnar arteries nicely visible to you, and this is the label part of it. Now guys, this table covers all the attachments, the proximal and the distal attachment. You always ask me, do we need to learn the origin insertion? And I always say no, you need to learn the proximal and distal attachment, and if you are still confused, just read it accordingly. You are expected to know the proximal and distal attachment, and the more important part, the actions and the nerves who are controlling these actions. And this is the arterial plan. You can see the whole arteries, and these arteries, you should be, this much is required for each artery, that what is from where it's coming and what are its main branches. Now what are you looking at? Look at this forearm, and a surgical incision has been made. It is splitted. What is this happening? This is a very important, and this is the same example within the thigh. So an incision has been made. The depth of the incision is up till my deep fascia. Deep fascia has also been splitted. You can see the cut margin of that, and we are directly over the muscle. Why we need to do that? This condition is called compartment syndrome. And what happens? What are the different factors? After fracture, if somebody apply a very tight splintage, or there is some internal trauma, that might result in the increased pressure within the compartment, and that will result the compression of the neurovascular bundle, and that will lead to future gangrene of the distal part. A badly bruised muscle, and then after the crushing injury or the burn injury. So these are all conditions. They may predispose to, not necessarily always, but they can be leading towards the compartment syndrome. And now this is the detail of this compartment syndrome. It develops when the swelling or the bleeding occurs within a compartment, and because the fascia does not stretch, so this causes increased pressure on the capillaries, nerves and the muscles in the compartment, and blood flow to the muscle and the nerve cell is disrupted. Without a steady supply of oxygen and nutrients, nerves and muscles, and they can be damaged, and they can go into gangrene, which is an irreversible type of injury. So to minimize that type of thing, if we are suspecting that the proximal pulses are not recordable, so these type of splits has been made. And how we secure it? Look at it, the edges of the splitted part of the skin, and there is this rubber strings has been applied with these staple sutures, so that the wound is not completely closed, but it's not open even. And once the things get settled down, we are removing these things and we are going for a definitive repair. Thank you very much.